thank you to everybody for coming this afternoon. When Dave and I were talking about this, and I've had the privilege of speaking with Dave on many occasions and getting to know the Price family, and I'd just like to acknowledge that Dave's family is here. We thought that as we wanted to present Greg's story, it would be useful to put into context the medical journey that Greg had before Dave tells you a little bit about who Greg actually was. So I'm just going to cover that in a very brief time here. So very briefly, in April of 2001, Greg was a pilot. He needed a pilot's medical examination, and he went to a local family physician for that, where an abnormality was noted around his right testicle, and it was recorded as a thickening of his epididymis. There was no distinct follow-up plan for that because the significance of it was not clear. In December 2001, many months later, he started noticing some back discomfort. As you'll learn, Greg was an athlete. He put this down to some back strain related to his athletic endeavors. But in January 2012, he went to see another doctor for a different problem, which was just a simple rash. And he went to a walk-in clinic in a different town, saw a doctor. Treatment didn't exactly work, so he decided to go back and see the doctor that had done his pilot's physical in February. And at that time, the doctor decided he would re-examine that epididymis to see if it had gotten better. It had not, and it decided that he would refer Greg to a surgeon for a second opinion, expecting that would take a couple of weeks to do. It turned out that Greg didn't hear from that office for 94 days. Meanwhile, Greg's back pain started becoming worse, and Greg decided to go and consult with the doctor he'd originally seen about his rash at the walk-in clinic. That doctor decided that he would order some ultrasound tests and some x-rays. It took Greg approximately 7 days to get in to get the ultrasound done, and when he got the ultrasound done, it showed that he had an abdominal mass that was pressing on his inferior vena cava. The radiologist came out and spoke to Greg about that and said he needed an urgent CT scan. She also phoned the family or the walk-in clinic doctor to tell him the same thing. And 7 days later, Greg was able to finally get back into that walk-in clinic to have the discussion about getting the CT scan ordered. Although it was deemed to be urgent, because Greg had suspected cancer, not known cancer, it was deemed a priority 2 scan, which meant it needed to be done within 30 days according to protocol, and Greg had it done 19 days later. While Greg was waiting for the scan, the walk-in clinic doctor left the walk-in clinic unknown to Greg, and there was no doctor to follow up the results with. A week after his CT scan, Greg phoned the walk-in clinic, learned that the walk-in clinic doctor was no longer there, and was invited to come in and see another doctor he'd never met before, which he did, and he reviewed the CT scan results, which confirmed that he had a large abdominal mass, and in a young man like Greg, suspected that it could be a testicular cancer source and recommended an ultrasound of his scrotum, which happened the next day. Greg now needed to go see a urologist and was referred by that second walk-in clinic doctor to the urologist, and Greg waited. And a week after, having expected to hear from that office many days before, Greg phoned to find out why he wasn't getting any care, and learned that the urologist was out of town, had been out of town, and would be out of town for at least another 2 weeks. Greg phoned back to the walk-in clinic, got referred to another urologist, and was seen in relatively short order. 2 days later, Greg was scheduled and went in for an orchidectomy to remove the cancerous testicle. The first post-operative day, Greg had the experience of increased swelling and had now been on narcotic medications for a week or two because of the pain, and things were getting worse, and he wasn't sure what to do about that. The second post-operative day, Greg decided he needed to reach the urologist to get some advice because things were getting better, or getting worse, not better, and Greg, although it was a normal business day, could not reach the urologist's office nor anybody else that was covering for him. With no other options, he went to the emergency department. He was taken there by his father, Dave. They went to the emergency department after speaking to healthcare professionals who were friends, family members, and they were advised to talk to the doctors about the possibility of blood clots. When Greg got to the emergency department after waiting, was taken into the back room for an examination. Dave was not allowed to go with him until it was okayed by somebody in the back. Greg left the emergency department after they confirmed that he needed a cancer clinic appointment. It was being worked on. He would hear from them very shortly. He went home to convalesce at his parents' home, and the following morning he collapsed when he got up out of bed. EMS was phoned They came, they tried to resuscitate him. They took him to the local emergency department. He unfortunately was unable to be resuscitated. At autopsy, Greg was found to have massive pulmonary embolism and massive clots distal to his obstruction from his IVC pressing tumor. That was Greg's medical journey and experience with the medical system. I'm going to turn things over to Dave so you can learn a little bit more about Greg and also Dave and his family's experience with trying to help healthcare change.
Well, thanks, Dr. Flemons, and I'd also echo earlier thanks for everyone taking the time to come today and to learn. It's certainly a new opportunity to be able to try and engage and have the public better understand what's going on with things like the assumptions that we make. I'm not as polished as some of the earlier speakers, so if I'm looking around bewildered, that's because I am. There's no monitor here, though. Oh, up there. Okay. So this is the time continuum that kind of shows what Dr. Flemons actually talked about, and you can see from it, and certainly you can refer to it later in the HQCA report on continuity of care. I would like to publicly acknowledge and thank Dr. Flemons and the team at the HQCA, including the board, for the courage that they took in actually taking on this investigation and being willing to go through it and spend time with us, which we certainly appreciated, in being able to learn more and to be able to communicate what our experience was after Greg's passing. A little bit about who Greg himself was. There we go. That was supposed to be the one that you were seeing. Now you can look at this one. So he was born on April 5th, 1981 here in Calgary, actually at this hospital, and raised on our family farm, mixed one about an hour outside of the city here, a big metropolis of Acme with a whole 600 people in it. I had 2 brothers and 2 sisters. Some of those are here along with my wife today. And he was always a happy youngster, always keen and willing to try anything. And then as he grew up and graduated, he spent time enjoying sports. He loved being fit. He spent quite a bit of time doing that, engaged in the fundraising runs and bike rides that would do that for different causes. He played on a number of different teams, both in and outside of school, community teams. Loved baseball in particular. Also played on high school basketball, competed at the provincial level, and also gave back. He came back and helped coach both school and community teams. Once he graduated from high school, he went to the University of Alberta, graduated from there as a mechanical engineer. And he went to work in different areas. He spent time locally working for a fabrication company that builds machinery both for the oil patch and for agriculture. From there, he decided he wanted to be able to be involved in something bigger, and he actually worked for a Schlumberger. He spent time in different countries around the world and really ended up missing his family and his friends at home and the sense of community there. He came back, became employed with a smaller gas company in Calgary, and used to live and commute from our home community. He always enjoyed helping out friends, and he loved, as you can see in the picture on the right, he loved the next generation, his nephew, and indeed, as Ward mentioned, during the process he earned his pilot's license and liked the opportunity to be able to take friends and family with him on trips that he could go on. One of the things that we learned after Greg's death was that he kept what we call little books of everything, and in those he had a number of quotes that he used to guide him forward. And here are 3 of the quotes that we took out of those books kind of demonstrate the kind of person that he tried to be. And I'll just read those quickly. The men who try to do something and fail are infinitely better than those who try to do nothing and succeed. My best friend is the one that brings out the best in me. A century from now, it will not matter what kind of car I drive, what kind of house I lived in, or how much money I had in the bank. But 100 years from now, the world may be a better place because I was important in the life of a child. Greg was tenacious in the pursuit of his goals, whether it was fitness or in the business that he's created or the work that he was doing for others. He always looked for the best in people. He was selfless, he was respectful, and those things made him very vulnerable to the current medical or health system. As a family, we only knew about the seriousness of Greg's condition when he chose to bring us into the picture on that. He was worried about us worrying about him. He told us after a fair amount of pressure from his mom on a Sunday night about what he had come to believe his situation was. We attended the examination by the surgeon on Monday, the next morning. After that, he wanted to write an email and send that out to his friends and family just to bring them into the picture. Wednesday, he was operated on. Thursday, Dr. Flemons talked about the swelling and that concerning him. Friday, we organized for the trip to emergency. Saturday morning, he died in our home. So, go ahead and play the video now, please. This is of his email.
Okay, one of the things that Greg did when, after sort of getting to the point where he had realized exactly what was going to happen and had confirmation from the doctors involved, was to inform his family and his friends. And he did that by writing an email that he sent on Tuesday morning prior to going into surgery on Wednesday. And here's what he had to say in that email. I wish I had better news to be contacting everyone with this morning, but wanted to give everyone an update at once. Yesterday I was diagnosed with testicular cancer, or at least a 99% probability of. I've been experiencing some symptoms for a number of months, mainly lower back and abdominal pain, and over the last few weeks the diagnosis has led to testicular cancer that was confirmed yesterday. The abdominal and back pain is a result of a relatively large mass present in the back of my abdomen. I'm scheduled in for primary surgery to remove one testicle at Rocky General on Wednesday. It's planned for just day surgery with the possibility of one overnight. Tissue samples will be taken and sent to the lab to determine if the specific type of cancer cells. These pathology results will take about a week. This will give final confirmation of the diagnosis and guide the next treatment steps. Most likely treatment will be several rounds of chemotherapy and/or the possibility of further surgery. I'm sure that this is a little overwhelming and a shock to everyone, but I chose not to talk about it much until I knew for sure. Testicular cancer is one of the most treatable cancers with an extremely high cure rate. I am confident that I can come out of this in several months, stronger than ever. As a final note, I want all of you to know that while I haven't been forthcoming about my challenges and diagnosis up to this point, don't think that each of you hasn't been supporting me. I'm blessed to have the most incredible family and friends, and it is through this group of shared experiences, memories, and futures that I gather considerable strength. Christmas dinners, random road trips, bad jokes, late night movies, unexpected overnighters, acting like kids and playing with kids all make it easy to get up in the morning and look at this challenge as merely a bump in the road to be overcome and no more. Each of you gives me more strength than I will ever be able to describe, and for that I have all of you to thank. All the best and see you soon. Greg.
So, my talk is going to focus a little bit differently now, and rather than necessarily talking to the medical community. I'm also want to be talking to the public. And so one of the questions are, you know, why are we doing this? Well, it's what Greg would have done. I made the mistake of looking over at my family. Greg cared. He really wanted to make a difference in the world. At his funeral, a number of people got up and related their own experiences. And they talked about his genuine interest in them, how he connected, how he made them feel special. From our perspective, it's important to share Greg's journey, its lessons, and its warnings, and that's the work that my daughters have done in creating the website called Health Arrows. There, the full detail of our view of Greg's story is written. It's available there for anybody to use. The idea is to try and have people better prepared for what might come of them going through the system, and to be prepared for that and to not end up being caught in the same gaps that Greg tried to deal with himself. Our overall goal, of course, is to help try and transform the health system. So when we decided to start on this journey, and it was after we were confident that we would be more than just a grieving family, and that was the result of course, the work that the HQCA did and the fact-based development and recommendations of the report that they did. And early on, our decisions were that we didn't want to take any legal action. We wanted to make sure that the doors were wide open, that we'd be able to work with people rather than bumping against the barriers that would have those legal doors slammed down. And we also didn't file a complaint with the College of Physicians and Surgeons for the same reason. We weren't interested in individuals. We were interested in trying to be positive and affect system-wide change, a culture change that needed to happen. We wanted to be proactive, to provide positive reinforcement, and to publicly celebrate good work and improvements. There's good work being done. There's great people working. That's what we wanted to be able to highlight and cause improvement and to sort of continue and generate momentum for change, positive change. Our early hope, as I've said, is open engagement, and we were looking for early progress in three particular areas. After-hours care. That's one that's been surprising to us, that the tolerance level has been at a very low compliance level. And all we were looking and expecting to happen is if we shone some light on this, the standards of the college would actually kick in and be met. And that's not really changed in the 2.5 years since Greg's death, 2 3/4. Patient support access. Often you'll talk to people that say, well, there's no policy that says that you can't accompany your sibling or your child or your parent. As Dr. Fleming said, I was prevented physically from accompanying Greg to his last examination. And that kind of barrier still exists today. And in the digital electronic world, as somebody from the outside that makes assumptions about the healthcare world that we're spending billions of dollars on, keeping pace with the rest of the economy and the other sectors that are working, shattered by what we learned about the dysfunctional, fractional, facts-based, in a lot of cases, record system. And so there's clearly needs to be something done with that. It's decades behind what we're used to in the rest of the world. And our longer term hope, again, is to help dramatically change the culture, the actual culture of the system. We've had People before me talk a lot more eloquently about what that actually looks like and means and perhaps why, but it needs to change. So, what have we been doing, or what are we doing? Well, we cooperated fully with the HQCA, helped them and helped us with the understanding on Greg's journey. It was very good interaction on the area that they were able to investigate. The Alberta Health System part, we interacted with people from AHS, we learned some things there, but the reports are internal, confidential, not for our eyes or the public eyes. We've accepted invitations to speak provincially and nationally. People always have their own stories, and very often, probably like this audience, there's an awful lot of the audience are healthcare providers of one sort or another, and it's amazing how many times people will come up and they will start with, "I was lucky." That's a terrible perspective to have on a system. Why do you need to be lucky? And it's always a result of somebody intervening or some point that people were able to actually change the course of what was not a healthy direction for the patient, the loved one, or the friend that was involved. We've accepted invitation to work with others, and the family members are volunteering on other committees. We're doing what we can to try and have some good come out of this terrible tragedy. And of course, we've listened as patients and families have come to us to sort of share their stories. Heart-wrenching ones, just like you've heard speak about earlier, and you've had a couple digital stories about it. And the sad part is that they're no longer surprising. It's way too common. It's more than ever the reason for dramatic change. I have a nervous finger, but it obviously isn't being able to get through there. Normally it'd be a couple of pictures at a time. So what's been our experience? Well, we started out asking not to be handled. We just wanted to know the truth. Wanted to know what really did happen, where the gaps were. Recognized we were coming from a way behind the curve on what the information was. We asked a lot of basic questions, things that would help us put things in perspective. Many questions, few answers. Oftentimes it was explained to us, well, this kind of occurrence is normal. This kind of activity is normal. This time frame is normal, as if that should therefore mean it's acceptable. It's not the right measure. Normal isn't good enough in any other sector. You have to be working to get better. There's lots of barriers. We've had explained to us how complicated and how complex, how big it is. And a new expression for us, we can't boil the ocean. What a terrible perspective, really, to say that that's the task. A few other experiences. We waited 7 months for the medical examiner's report that contained a pretty significant error as far as we were concerned. It didn't document the fact that Greg had post-surgery swelling prior to and pre-surgery swelling prior to that surgery and running up to the emergency visit. We were surprised that they weren't prepared to correct it. In fact, I was asked if I could provide written documentation that that was a fact. Medical examiner's office is in the Department of Justice. It's a third party. It has all kinds of authority, more than anybody else. And yet that's what I was asked to do in order to get that error corrected. And even when it was provided, it was not corrected. We asked for a fatality review board investigation. That was denied. We got a one-liner basically saying, nope, not going to do it. We exchanged opinion letters and conversations with Dr. Thiemann and the CPSA, College of Physicians and Surgeons of Alberta, regarding what Dr. Horn had asked him or them about the recommendations in the HQCA report. That information is posted on Health Arrows if you want more detail of it. Certainly appreciated the ability and the willingness to talk to Dr. Thiemann and have those exchanges, but there's way more needs to be done than talk. There needs to be some serious action taken on everything from those after-hours care standards and on a number of other fronts that the CPSA has some influence on that come with the recommendations of the report. We had a positive experience with the AMA. We presented at the Representative Forum just about a year ago, and outcomes of that were resolutions being passed about directions or things that need to be done. They can't do it on their own, of course, and we would have hoped, and perhaps after today, we'd like to see quicker action, more progress made. So what have we really learned? Well, this is a patient's family's view of what the health system is. It's managed top down. It's all about command and control. It's a patient treatment system, not a patient care system. That culture pre-existed the former minister, but it certainly was hardened by the tactics and the firings that happened during that tenure. During our meeting with people and seeing good work done in different parts of the province, it's pretty clear to everyone they're not safe. If you can fire an independent board and get away with doing that and move on from there without any real ramifications, then nobody in this system or in the province is safe from that unless there's change, clearly. As I say on the slide, there's many good people. Oh. No, still, I had my finger going when I didn't know it. So the last point there, many good people and pockets of great care. I don't want to have the overarching theme here that everything's in the dumper. It's not. We've got great people doing great work. The problem is at the culture and the broad system level. The ones that are doing that work are doing it by their own admission, some risk to their own future, their own careers, and they also say at risk to their care for their patients. That's one of the frustrations that we had. One of the goals of the Health Arrows website was to shine a light on those people. Every time we talk about that, no, don't do that. No, we don't want to stand out. That's not a good thing. We will lose if we do that. What a terrible way to be looking at the world. Now we'll get to this one. So what do I mean about patient treatment versus patient care? Well, you heard a little bit earlier from the speakers before. Patient treatment's vertical. It's individual decisions, individual incremental actions, individual steps, individual payment, vertical. The other part of it is when it's done that way and accounted for that way, it usually means you're unable to measure and track what happens in the bigger picture. So you end up with just a bunch of pieces, not the puzzle. How can you possibly move a system forward and improve if all you're doing is looking at pieces, not the puzzle? You don't have the picture. Patient care, on the other hand, is a team effort. It's built on each member's strengths and how they can contribute to the end goal of the whole care. It is available 24/7. No patient is ever discharged from care. No patient is ever discharged from care. The team is in place 24/7 and it goes around. The other part that is important is that it is collaborative. It's engaging the patient in the decision-making partnership. It's a partnership. The patient has things to offer. They certainly have things they can deliver, and they can be part of the process of ensuring all the steps occur along the continuum. Greg knew his condition better than we did, and we believe better than the surgeon did. He asked questions around an alternative approach to his treatment. Major surgery, remove the mass, get the pressure off his IVC, and then move into the treatment on the testicular cancer after that. The response was that, we know what we're doing. We've done thousands of these. You're not going to die. That kind of dismissal. That's what we had. Another thing that, from our perspective, it was noted a little bit in my introduction. Our experience is in the food industry. We've had to work in an environment, and we are willing to work in that environment where there's a system in place to ensure that human failings and mechanical or process failings are covered. To put men on the moon and to put men into space, NASA developed a system in the 1960s, older than most of you in this room, that was called HACCP, Hazard Analysis and Critical Control Points. It was a way of looking at all of the what-ifs that could happen in the process to their outcome. In the food industry, we have to do that before we can open the doors and do business. If the lowest inspector in a plant detects or believes that there's a risk that's not properly accounted for, business stops. This audience here should remember what happened in Brooks a couple of years ago. 2,500 people or so out of work for a number of weeks. Finally, the Canadian Minister of Agriculture and Food needing to sign off before they could go back to work, a new ownership group, and then they could go forward with a new set of standards and be able to proceed from there. How many people actually died in that event? None. 14 were ill. The health treatment system that we have just keeps doing what it's doing. There's no interruption. There might be an investigation, but the business just carries on. What I'd like you to do now is think about from your own perspective, particularly those of you that are from the public. What are some common experiences? And I'd like you to stop and think about them. Is that a treatment regime, or is that about patient care? Brian did a great job of some of the things there, so I won't spend a whole lot of time on that. But he did the one on clinic receptionists. My question is, why are the gruff ones always hired? Why are they the ones that actually are at the front line? What other business could stand that? Really? What about the sign? See the picture there? You're welcome. Note, 1 issue per appointment. If you need another one, make another appointment. Is that treatment or is that care? The doc that tells us, as we were told, or as Greg was told, don't call us, we'll call you. The flip side, of course, is we've had those too. Sure, here's the number, call us anytime, or call the pager and they'll get me. Anytime at all. Pretty different treatment versus care. What I'd like you to do is stop and think about those experiences of your own. You'll have ones that we don't have. So, from our perspective, what's needed? Well, we start with new priorities and new direction for the new political leadership. We've got an opportunity now, as the public and the system, to be engaged and be part of establishing new priorities and directions. Since Greg's death, 3 premiers and 2 health ministers. It's too early to see change in the patient treatment system now. But what we need is strong public engagement to establish and set priorities required on all levels. We all have the responsibility, individuals, families, providers, indeed the media. Media has a role in this too. Stop and think, ask the questions. Does it sound like we're making progress? Or is it just justifying what's happening or reinforcing the treatment regime? Universities, college institutes certainly appreciate the forward-looking and initiative that's taken here at the U of C and what's happening here today. Training and attitudes start there. Start as the students go through the system. Whatever's happened in the past, there's a critical failure there because we've lost, as Brian said, we've lost some of that, the heart part. It's up here, it's not here. You got to remember those are connected and need to be balanced. So I'd encourage everyone to stop and assess decisions. Question whether it's moving things towards care, and obviously oppose and let people know you oppose those that reinforce disjointed and dangerous treatment system. I got 2 instead of 1. There we go. What's it feel like as a patient or a patient's family? Well, it feels like many people that work in the system either don't care or they're not allowed to provide real care. Either way, it's just treatment, right? The next part of that is, you know, Brian talked about having the smile, a happy face on. Well, it's not healthy for either the patient or the caregiver to be in a space that's like that. You need to feel good about what's going on. You need to be partnering in that care and have a bond with the patient so that you both can move forward and feel good about that and celebrate it. It can be tough stuff, but you need to work on it together. We need to work on it together. Just a few examples that we've had over the last, it'd be 6-8 months. Let you categorize it. The granddaughter was not very well, getting lethargic, run a fever, not normal at all. Had a trip to a clinic actually and had an assessment and, you know, go home and be medicated, be okay, just keep an eye on it. She's 3. Decided that that wasn't actually progressing. So after all hours, call to HealthLink. Go through the checklist, oh no, it's okay, just keep monitoring, it's okay. Time goes on, finally, her mother said, nope, let's go. We're going to go to emergency even though we're not supposed to need to. She was admitted and hospitalized for 3 days. Both of our daughters have had variable and disconcerting experiences, both on communication, on continuity, and certainly the care treatment angle. And on the flip side, our youngest son had prompt and outstanding care. Very efficient, very focused, very care-driven, and had quickly dealt with his fears and concerns, and he was happy to move on from there. So, take-home messages. Whenever we feel we faced a challenge, Greg's grandfather told us, you've got 2 choices. You can either be part of the solution or you're part of the problem. Doing nothing is part of the problem. So my ask, let's all be part of the solution. Every Albertan needs or will need care that is safe, continuous, collaborative, and patient-centered or partnered with the patient. That care culture does not currently exist across the system today. We all have to change that. Thank you.